So I would like to invite to the dais the representative of Ministry of Health and Social Welfare, United Republic of Tanzania as a co-chair. Please. Yes, please this side. Good morning. Okay, we're going to start today's session. First, the session will be the recap of the second day, and the recap will be done by Dr. Nima and Dr. Nancy, and that will be the feedback from yesterday group work. So I would like to invite both of them, Dr. Nima and Dr. Nancy, for yesterday group work feedback. Please. Janam. Slide.
Good morning, everyone. I will be presenting the report back from the group work on on-site support. And we had four different groups. And we have the facilitators' names there, the team of facilitators that supported this. We had very rich discussions, and we went through the questions in the guide. So how we organize the feedback is, I'll take you through some of the key things that came out from the discussions, and then the summary in terms of what were the key lessons learned, and what are some of the short-term and long-term plans that we have moving forward. So on the question of whether countries are implementing team-based QI activities in facilities, most countries are implementing national quality improvement strategies and frameworks with a national approach to QI teams. However, in most countries, not operationalized to full coverage. Some are still in the process of developing national documents and frameworks, and they have partner-led QI teams in selected regions or districts. We found through the discussions that there was still also some confusion in terms of exactly what QI teams meant and supportive, and there was confusion with supportive supervision. And also we found that there was different understanding on the QI team approach within country participants, because as you know, the countries were divided into two groups. Quite a number of countries have harmonized approaches to QI. The challenge is that even those who do have harmonized approaches in terms of national documents, some are still struggling with partners to align, because partners will still come and want to use their own systems, either through programs or it could be through different programs, but also just within the same program because of the quality improvement method that they are used to. Most countries have team-based QI focus with national QI teams, regional district QI teams. At facility level, they have facility QI support teams. And in big facilities, then they have work improvement teams. So the work improvement teams are department-based, for example, like in the labor ward or pediatrics or the different departments. And members from the work improvement teams then form the overall facility QI team. So again, the challenge is operationalization of this that we find in most countries. We don't have national coverage, or there's limited coverage of this. Our staff identified and trained to become QI coaches. We found that in almost all countries that yes, there was a need to do this, and the people who are trained are either doctors, nurses, midwives. Some have teams from a broad range of people, including WASH and other aspects. Professional associations were involved in many countries, academic institutions, and centers of excellence. Also, QI focal persons at national, regional, and district level, in some cases, were also identified as mentors and coaches. Now, we found that there is a mix in terms of who are the QI coaches. We found that some are trained both as QI coaches and clinical mentors, meaning that they do both the clinical mentoring, they're expected to do both the clinical mentoring and the QI coaching. Some have different clinical mentors, so some are only clinical mentors, and others are only QI coaches. So the challenges sometimes when the QI and the mentors are different, synchronizing visits between the clinical mentors and QI coaches is a challenge. And then the additional cost, because now to achieve both, it means you need to fund 2 people to go to a health facility. The other challenge was that with using academic institutions, sometimes the academicians' perception of quality may be different in terms of what they would like to achieve, because they're more academic focused. In terms of who or how they are selected, in most cases, it was those who would be selected, those who do well in QI training and found maybe picking up the practice in their health facility. So it's either they just do well during the training, or also on follow-up after training that they actually seem to be picking up the practice in their facilities. For the clinical mentors, the OCSE score was used in terms of identifying clinical mentors. Our staff, okay, so more in terms of the QI coaches, what is the frequency of the visits? And we found that this ranges from 15 days, every 15 days, to monthly, to quarterly. We also found that there were few instances in which WhatsApp platforms and telephone calls were also used for mentoring. Duration of the visits ranged between 2 to 5 days. The number of health facilities that a coach would support ranged between 2 and 18. And I must say that for the 18, it was in a case where the mentor was just, the sole responsibility was just to do coaching of that person. So the challenge is that time coaches spend away from their primary work may become a challenge, and sometimes their supervisors are not happy because of the time that they have to spend doing coaching in other facilities. So during coaching visits, what actually is being done? So this was quite a hazy area. In some In some cases, they talked about assessment of identifying gaps, reviewing improvement aims, analyze data, problem solving, participate in working areas, skill stations, and then prepare reports in an organized format according to the training that is available. So again, this was an area where in some cases we found it was very hazy between actually QI and clinical mentorship. Challenges included availability of mentees, that when you go to a high burden facility, sometimes they have to attend the patients first, so it limits also the time that you can actually spend with them doing the QI coaching. How is QI coaching being integrated into healthcare worker roles and responsibilities? First, are the coaches government employees? We found in many cases they were mainly government employees. They could be, and also, as we said, professional associations, academicians, but we also had coaches that were employed fully just by partners, and they would actually go to support the health facilities, but they are not within the system. So one of the challenges is that even though we said mainly most are government employees, they are mainly supported by partners. So you depend on partners to run, for the logistics to manage the coaching. So it was only like in 2 countries where mostly government was covering this. In almost all cases, coaching was mostly an additional responsibility and not part of the roles and responsibilities, except for focal persons at different levels. In few tertiary centers, they said that coaching was within the roles and responsibilities. We found 2 countries who had examples where mentors or the coaches had the sole responsibility of coaching. So the challenge again, that supervisors of coaches may not be supportive to allow absence from place of work for coaching. And then also, because it's not part of their primary role, then coaches also have to be incentivized as it is an additional responsibility. So it's not just per diem. In other countries, they're also talking about paying honoraria to incentivize the coaches. Coaching function across the board, we found, was not really integrated into HR planning. Logistics, mainly supported by partners. As I said, only a few countries are covering this. Sometimes transport is supported through government. Coordination of coaching visits, we found, it ranged from being coordinated from the central level, and in some cases from regional and district level. So again, challenges include sustainability and inadequate number of coaching. Is there a standard? For QI coaches, we found, yes, training packages are there in most countries, and those who don't have are in the process of developing packages. But then there is a range of what these packages are. So some have clinical mentorship with some QI in it. Some have QI coaching. Some people who are trained on QI are then separately trained on coaching skills. So there's quite a range here. And as we said, we found that the whole issue of the actual QI coaching was still a hazy area, and I think we need to look into it. The other thing was partner non-alignment to the national packages. What does the training include? As we said, training on QI approaches, the role of the coach, and the role of the healthcare worker, activities to carry out during coaching visits, problem-solving tools, and data analysis. So these were some of the things that came up that are in these coaching packages. Training approaches are harmonized in few countries. We found generally there was no systematic approaches for continuous development of coaches. And again, the challenge of partner non-alignment to national packages, attrition of trained coaches and healthcare workers. Sorry, oops. Okay, no, that's in it. Okay, so Now, in terms of the summary, in terms of, what are the lessons learned and some of the short and long-term plans, we have not defined, we didn't have time to really define each one to say whether it's a short-term or a long-term, but I think as we look into these, one can say can look at them and judge which one's a short-term and long-term. So in terms of lessons learned on selection of coaches for QI need to be looked into, coaching for QI needs to be looked into and strengthened. There's still a gray area on QI versus clinical coaching. There's a need to consider pros and cons of having separate or combined QI coaches and clinical mentors. If they are separate, visits need to be synchronized, and even if you do have them separate, then participants felt that clinical mentors should at least be trained on the basics of QI approaches. Mentors or coaches should be within the health system for sustainability. So it was felt that it's not really helpful to the system when you have a partner-supported QI coach that is outside the system, because if capacity is not built within, then it's not sustainable beyond a project. Then it was also discussed that maybe there's a need to really look into and define coaches, what is QI coaching properly, and then also what are mentors, and also look at the tiers, to have tiers of coaches for the different levels and what would be their different roles and responsibilities. Coaches should also have, should also have practical skills and application of QI approaches. And then we also emphasize the need for both external and internal coaches, and that even if a facility is now doing well and has picked up, we said they should not be totally graduated from external coaching, but the intensity of coaching could differ when a health facility has picked up well. So some of the short-term, long-term plans, pre-service training to include QI, including training of tutors, include private sector in coaching, design motivation packages for coaches, develop standard criteria for selection based on expected roles and responsibilities, develop facility-based internal coaches, and also to define the job description of each coach. On the training, we all agree that it is important to have a standardized training that, irrespective of where the funding is from, once you agree on a standardized format, then everyone should align to that training. Leadership is needed to ensure alignment of partners and vertical programs to standard packages. Content of training should include QI coaching skills and should not only be QI or only coaching. Set up systems for evaluation of coaches. So we found, I think there was only 1 or 2 countries that talked about having a system to evaluate coaches. Coaches should build capacity of others to develop internal coaches within the facility. So again, for other countries, develop training guidelines, develop plans for continuous development of coaches, develop systems for learning among coaches, refresher training of coaches, develop tools for assessing coaches, identify topics that should be included in training packages, review existing training packages to fully address the actual QI coaching skills, integrate QI training into training for clinical coaching, consider things like certification or link up training on coaching and on QI with achievements like CPD, things that need, that are in line with certification in different organizations, professional organizations. Then in terms of managing on-site support, lessons learned, government needs to take leadership and coordinate, because we found even when logistics are supported by partners, then sometimes even, the whole coordination is not led by government in some cases. So the government needs to coordinate. We felt that sub-national levels should manage facility level coaching for ownership rather than national level, because in several cases, even coaching at facility level is managed and coordinated from national level. Then that gives a sense of a sort of like project approach. We found that duration of coaching is varied, and varied activities actually take place during coaching. Therefore, this may need further review by countries. External coaching is important to keep up enthusiasm and action. M-Health platforms can be used for on-site support, and then intensity may be varied with more frequent mentorship in the beginning and less visits as facility matures. Also, pool of coaches need to be increased. Otherwise, it becomes a challenge if coaches have to leave their primary work for prolonged periods of time. So among the short-term and long-term plans, consider use of M-Health platforms for coaching, and also it was also suggested that consider flexible plan for external coaches. If they're few and they're busy, then also to have a system where external coaches can actually plan when they would be available for coaching. It may make it, it may improve in terms of the logistics. Funding, again, we said funding we found was mainly supported by partners. So in short, some short-term, long-term plans consider funding through central government budget, districts to include funding through district plans. Others talked about maybe to put policies in place that it will ensure a certain percentage of funds in the Ministry of Health budget goes to quality of care work, and also then to generally develop sustainability plans. In terms of, I think this is the last one, integrating coaching into government system, the importance of having a national framework and system for coaching, partner alignment to government guidelines, ensuring government funding and use of coaches that are within the government system. So among the plans, some of them are similar, have already been raised before. Maybe in addition, HR planning for QOC, policy to ensure, make the coaching part of performance appraisal of coaches, that meaning that having it as part of their job responsibility, and also including chief quality officers as coaches for monthly and quarterly visits. So thank you. She has data system with a different group. Okay, yeah. Please start.
Good morning. I will just present a summary of what we discussed in the 4 groups that were dealing with data systems for quality of care. Suffice to say that we had a 1-day meeting where we also discussed the data issues in length, and I think the findings of that will also be shared later as part of the workshop document. We actually just summarized in terms of what to do and what not to do, and then what to incorporate in the country quality of care program. From the country experiences, we learned that it's important to establish efficient data flow systems from the community all the way to the national level. The other thing that was shared by many countries was that when introducing an electronic system, it's important to maintain some overlap with the paper system until the electronic system is well established and validated. The other issue is to designate focal persons for data who understand data elements. Examples were given of people entering data just because there's an empty space, they will enter some data in that space, even if the data does not exist, because they don't understand the implications of what they are entering. Involving users of data is very, very important. There is need for a uniform understanding of the common core indicators. For instance, an example was given of the common core indicators talks about pre-discharge maternal mortality. And there is a problem understanding that vis-a-vis institutional maternal mortality. So there is need to have that common understanding. There needs to be a mechanism for collecting data on experience of care. Countries shared their experiences with this, but there's need for more guidance, and also for data where the elements are not already existing in the DHIS. So what do we incorporate in country quality of care programs? There's need to overlap paper and e-systems for some time for validation of data. Let us remember that e-systems are not foolproof because we all know that garbage in and garbage out. It is human beings who enter this data into the e-system, and therefore the users of data or the ones that generate the data really need to be involved in this. It's important to expand the pool of health personnel managing data to cater for attrition. This was in the light of the fact that a lot of data capturing or consolidation is supported by partners who either go away with the database or they have a parallel database to the one in the MOH. And when that project is over, then there is no data for the Ministry of Health or very, very limited data. So it's important to really expand the pool of health personnel managing data to cater for attrition. Harmonization of data sources so that there's common understanding on information captured, especially on the common core indicators. It was proposed that selected indicators and not all the indicators should be included in the existing DHIS2 because already there is overload of the HMIS and we need to be prudent in our selection of the indicator or the data elements that will be included in the DHIS2. However, it was reported that for many countries, most of the data elements are already in the DHIS2. So that really makes it easy to collect the indicators. The other thing was to align the indicators in the common core indicators with national definitions. An example was given of kangaroo mother care, where the cutoff in the common core indicators is 2,500 grams, whereas in the country definitions is 2,000 grams. So we need to align that to what is in practice. On the issue of collecting, analyzing, and using improvement aim-specific data, it was noted that there are too many tools, too many indicators, too much data, and parallel data systems. However, for most countries, they have quality improvement or performance management teams at different levels, including the community. There is need, it was emphasized, the need for data transparency. For example, when the health facilities display their dashboards or trends in the facility so that the staff and the clients can also be able to see. Countries gave examples of mobile feedback system, especially for experience of care reporting that were in place. The need to validate data. A lot of examples were given on the practice of falsifying data, especially in the context of results-based management, or massaging data or doctoring data, especially when there is some monetary gain to be obtained by showing improvement or showing numbers. The capacity in data management also was a big issue. So in the country program, there is a need to harmonize the different players in quality of care data. So for each country, find out all the people who are having a stake in quality of care data and sit together and harmonize things. We had the advantages of having M&E focal persons from countries or people who manage the HMIS who explained the process of getting a data element into the HMIS. And for some that don't exist at all, I think it's a very long and tedious process and may include even revising of registers to include particular data elements that are not already in existence. There is need to institutionalize data transparency mechanisms in health facilities and communities like the scorecards. Capacity development is in data management within the system, especially if previously donor supported. And we still are urging countries to explore or scale up use of electronic data capture, but with the validation element. Improving skills on data collection, analysis, and use. There is training of data focal persons and designated health workers for data entry. We got some good practices of pairing statisticians with technical officers, especially to mitigate entering strange things into the data system, because a lot of the data people are not technical. So some countries have practiced pairing them either with a midwife or a neonatal nurse when they are entering the data so that accurate statistics are entered. We had an example in one country where under 5s were being recorded as being pregnant, and we do know that that is difficult. Sustainable skill building. We need to move from data consultants to people within the system and use existing staff and improve retention of data focal persons, especially in light of, it was discussed at length that we spend a lot of resources to train people within the health system to be data focal persons. And after we have done all that work and they are proficient and doing this work well, then they are poached by some partner and they later come to give oversight over their colleagues that they left like 2 weeks ago. Capacity building on common core indicators, we have already talked about that. What we incorporate in country programs, the importance of training the data users in the value of data. And we all remember trainings that have happened in data for decision making. There were examples given on conducting campaigns on data use and conducting random checks on data entry and include DQS in reviews. In terms of improving data quality, validation came up very frequently at all stages of data management. Triangulating data from various data sources, empowering health workers to use data, data verification and validation, real-time data collection, and assigning responsible person for quality of care data collection, reporting, and analysis. Here, I will just pick up one recommendation for the Secretariat that it was felt that the network should institute a regular data monitoring system for the QED network. And then the standardized tool on experience of care, and also it was felt that WASH indicators are also giving a problem in terms of really validating. There is no way you can prove that if I have written I'm washing my hands after examining every patient and I report that. It's difficult to validate unless you come and stay in the facility for forever. Building a stronger culture to support data use for problem identification and solving. What to do and what not to do. It's important to tailor data collected to routine needs of the health worker so that they can use it for quality improvement and appreciate the value of the data. Strengthening the MPDSR platform for quality of care improvement, and in building system alerts for response to MPDSR recommendations. We got excellent examples from countries on that. Inclusivity of all partners, so data surely should not be secret. Quality of care data, promote utilization of data, and regular QI meetings for problem identification and QI planning. I will just select a few things here. The countries need to have and to implement a national data strategy and not just implementing data things ad hoc. Instituting data transparency mechanisms, stronger M&E officers at ministry level, and harmonizing data systems and encouraging use of data at local level. Adapting existing data system to measure quality of care. There's need to harmonize the national QI indicators. The problem of too many indicators in HMIS from different partners. And this is mainly happening because many countries do not have a data strategy. So the partners, they lobby and they have side meetings, like when we are here, like now, so many meetings are going on for certain indicators to be included in the HMIS. And there is really a need for countries to have a data strategy where all indicators must be derived from and fed into, and this should be country-owned and country-led. It's important to strengthen MOH leadership for data systems around quality of care data management. This is in light of the fact that we already said a lot of the data is residing with partners and not with the Ministry of Health. And in some countries, the ministry literally have to beg the partner to give them their own data elements for reporting. So there's need to strengthen MOH leadership around that. Adapting data collecting systems, learning from other countries so that you can be able to capture indicators which are not currently in the HMIS. Measurement strategies to track implementation of quality of care activities. There is a challenge in tracking experience of care and WASH indicators. If you are digitalizing your systems and using online platform, you still need regular monitoring and supervision. There's need for regular QA program review among the learning districts. Examples were given about convening quality summits regularly to look at the data you are collecting and strengthen country-led data collection and reporting mechanisms for the common core indicators. What to incorporate in countries, multiple data capturing system, at least in the beginning, to allow for source verification, strengthening data monitoring, WhatsApp group to track progress, and incorporating discussions or review of data into regular facility meetings. So what is working well? Plans and intentions to collect data, systems for data transmission in place, human resources for data collection and transmission is working, digitalizing of data is ongoing, quality of care data, TWGs or working groups are there at different levels, DHIS2 is in place, innovations are abundant, sharing facility data with health workers or displaying it, and several best practices have been shared by countries. What is not working well? Multiple tools, bulky HMIS, load of data at lower levels is very high for the collectors, under documentation, real-time data capturing, institutional culture for data is absent. Many times clinicians don't look at the data, weak utilization of data for decision making, ownership, especially by the data generators, is weak. The issue of data verification mechanisms, they are really not in place or they are weak. integrating community components to facility is not very strong. Leadership for quality of care measurement and data and monitoring and evaluation for data is actually quite weak. Integration of common core indicators into DHIS is still in infancy. Data focal points, like we said, don't have clinical background. Data quality, completeness, timeliness is still a problem. And then there are some indicators that are not amenable to routine data collection because verification is difficult. Like the indicator on correct use of pathograph or active management of third stage of labor or hand washing. These are indicators that need direct observation because they are difficult to verify off-site, and then loss of trained personnel. Thank you.
Thank you, Dr. Nima and Dr. Nancy. I think it's an excellent, wonderful reflection as well as the outcome of the yesterday group work feedback. Actually, network country member would be able to integrate this feedback, this reflection, and this outcome in their own system and need to customize where it necessary. Also, the guest countries might take this opportunity for incorporate this feedback in their own country perspective for ensuring the quality of care in M&A services. So I would like to thank the two feedback pickup with a big hand. So now we are moving to the next session, that is panel discussion on learning system. Country experiences implementing national learning healthcare system will be presented from 3 countries. Number 1, Federal Ministry of Health Ethiopia, 2, Ministry of Health Uganda, and 3, Ministry of Health and Family Welfare India. I would like to invite all of them to the dais. Actually, the main outcome of this session is to share understanding of emerging experience and practices in integrating learning to support implementation